you had a talk on chronic systolic heart failure in the CSI. So I would like to ask you, sir, what is this chronic systolic heart failure and how commonly you see in your practice?
As you know, heart failure is a clinical diagnosis. It is diagnosed mainly on the symptoms and signs of the patients. But when you suspect it, you have to do some diagnostic tests to confirm your diagnosis. The most important test is the echocardiogram.
Right, sir.
A properly done echocardiogram gives all the clues regarding the presence or absence of heart failure, type of heart failure, whether systolic failure or diastolic failure, I mean with reduced ejection fraction or preserved ejection fraction, the complications of heart failure,
right,
even the causes of heart failure like valvular heart disease or ischemic heart disease. So echo is the all important single diagnostic test which you need for management and evaluation of systolic heart failure. Secondly, if there is some confusion or echo is not readily available, you can have the biomarker test like BNP. Actually, the Western population and Western guidelines emphasize to some extent on the biomarkers, which is not so popular in the Indian scenario. Firstly, because it's costly, and secondly, it gives some dubious results. So it's more of exclusion value, right, rather than diagnosing value. So a heart failure is supposed to be the commonest chronic cardiac disease which affect the adult population worldwide, and it's the biggest taker of the health budget from the cardiological standpoint, even worldwide and in India as well.
Right, sir. So you talked about BNP and NT-proBNP. So even in the latest ESC 2016 guideline talk about the echocardiography, NT-proBNP. So what about the ECG? Even they are talking about 12-lead ECG is very important. So
ECG is mandatory, but it doesn't help in the diagnosing of heart failure. It gives you clue regarding some causes of heart failure. Like if there is a heart attack, you get the QS pathology in the ECG, and you know that it's an ischemic cardiomyopathy rather than a dilated cardiomyopathy.
Right.
And heart failure is often associated with arrhythmias, like ventricular arrhythmias, like atrial fibrillation. So those can also be easily picked up in the ECG. But ECG per se is not diagnostic, right, for heart failure. It does not include, does not exclude the diagnosis of heart failure.
Right. And sir, how commonly you see this kind of patient in your practice in the eastern part of the country?
As I said, as the population is growing in age in India as well as in eastern India, we are getting more and more heart failure patients. And particularly with the increasing epidemic of diabetes and hypertension in the population, we are getting more heart failure patients.
Right.
And the survivors of heart attack.
Right.
When a person has got a heart attack and dies straight away, he doesn't survive to become a heart failure patient. But nowadays with modern management of myocardial infarction, you get more and more survivors, and they actually present with heart failure, many of them. So it's an ever increasing population of heart failure even in eastern India.
Right, sir. And how do you manage these patients, sir?
Heart failure, chronic systolic heart failure, once you diagnose, the management depends on two basic things. One is the decongestion of the patient, because the patient usually comes with excess water in the body.
Right.
And diuretic is the main stay of therapy over there. But diuretic is not the long-term therapy, and that's not a definitive therapy. So next you have to think of the definitive therapy, which actually increases the longevity or improves the prognosis in heart failure patients. And there are very well-defined medicines with very proven benefit.
Right.
The number one group is ACE inhibitor or ARB. Number two group is beta blocker. Number three group is mineralocorticoid receptor antagonist.
Right, sir.
These three, and then followed by the recently developed ARNI, as you know, the new RAS blockade,
right,
and ivabradine. These have got their own places,
right,
down in the algorithm in the management of heart failure. And as you know, the commonly used drug like digitalis, who have got very little role, right, in the present day recommendation in heart failure. And of course, there is a huge role of the device-based therapy when the patients are not controlled symptomatically with these medicines I have already mentioned.
Right. So, sir, how commonly you see these device-based therapies in India nowadays?
Device-based therapies are growing, you know, because as I said, the number of heart failure patients and terminal heart failure patients are increasing. And medicines, though sound very good that they improve prognosis, many of the medicines are not tolerated in the appropriate dose, and there are contraindications. So many people cannot take the few advantage of the pharmacotherapy that is available nowadays. So we resort to the device therapy. One is the biventricular pacing. or CRT therapy, as you know, they have got specific indications for that. You cannot just offer it to any patient. So you have to be very choosy about whom you offer this, and then also it is so costly.
Right.
And on an average population, if you offer to 100 people, maybe 10 people will be able to take it up. 90
Right.
people won't be able to take it up because of financial reason. Then there is ICD,
Right.
that is a defibrillator. That is in advanced heart failure, people die of VT and VF cardiac arrest to prevent that. And also there is role of left ventricular assist device. And though it is just starting in India, but I think the prospect is good for heart transplant. Perhaps you have known that there are different centers of India now who are actively starting various centers in India, north and south, east and west. They are taking up into active cardiac transplant programs. Though it is a very infant stage, but I think over next decade, there will be some hope for the Indian patients who are terminally heart failure ill.
Right, sir. Thank you, sir. I will ask the last question. So, what's the indication for this ICD or CRT when you choose for your patients?
CRT is chosen when the people are taking the maximal tolerated pharmacotherapy, still in NYHA class 2 to 3. I mean, not 1, but 2 to 3 is advanced heart failure. And when they have got the left bundle branch block pattern in the ECG, and the duration of QRS is more than 150 millisecond, then you really anticipate some benefit.
Right.
If you compromise in any of these criteria, then it is an off-level indication or 2A class indication, and then you may not get the full benefit of CRT.
Right.
And ICD is actually, after certain trials, it was blanketly indicated for all people with heart failure ejection fraction below 35%. But then the whole budget of health will go into just putting the ICD to all Indian patients, even might exceed that budget. So we have to be choosy. People who had survived sudden cardiac death, who have got some malignant VT or VF or too many ventricular ectopics seen in their ECG or Holter monitoring.
Right.
On those people who have got family history of sudden cardiac death, those people we choose and offer ICD. It is relatively cost effective.
Right.
And much more cost effective than CRT therapy.
Thank you, sir. May I request you to just summarize in 2 sentences about your talk, sir?
What I can say in 2016-17 now, that management of chronic systolic heart failure is very much streamlined and guideline dependent. But at the same time, immense judgment is required to treat individual patients depending on their socioeconomic condition, their mentality, their psychology, and the exact physical condition. Failure is a clinical diagnosis. It is diagnosed mainly on the symptoms and signs of the patients. But when you suspect it, you have to do some diagnostic tests to confirm your diagnosis.